Good afternoon. Thank you for inviting me. What we're going to do today is talk a little bit about myasthenia and also talk about the ocular component, because the two are intertwined. And about 80% of patients are going to have symptoms in the body and the eyes, and 20% are just going to have symptoms in the eyes. So part of this is going to be academic, part of this is going to be scientific, and part of this is going to be practical. And then we have some questions at the end that hopefully will help everybody understand a little bit more about what I do as an ophthalmologist for myasthenia gravis. A lot of the information that has evolved in the last 5 or 10 years was recently summarized in a very nice article in the New England Journal of Medicine, and that's listed at the bottom there. So for those of you who are academically inclined, most of the pictures in the slide and the tables and charts that I have are showing today are from that article because it was just published last December 2016. It was a group of international neurologists who sat down and just wrote a summary review of myasthenia gravis and why it's important for all of us. So again, I may be preaching to the crowd here, but bear with me. It's a disorder of neuromuscular transmission resulting of blocking of antibodies to components of the neuromuscular junction. I'm going to show a picture of that in a minute, but that's essentially what the disease is. Now, the problem is you got muscles and nerves all over your body, and they do all kinds of things. Why is myasthenia so specific? Because there are some nerves and some muscles that do things more specific than others, and those are the ones that are affected by myasthenia. Weakness of the hands, hoarseness of the voice, difficulty swallowing, drooping eyelids, and double vision. Why is that important? Because when we're aligning our eyes together and moving them, we're talking about things that happen within a millimeter. If your eyes are off a millimeter, you see double. Very precise. My hand doesn't need that kind of resolution. My eyes do. My voice box does. My swallowing does. There are things that require a lot of nerves to a lot of muscles for a very precise activity. And if you just drop some antibodies in the way of that, it produces this havoc that I see as ocular myasthenia. Antibodies to the postsynaptic receptor are the most commonly identified in myasthenia and occur in about 90% of patients. Well, why is that important? It's important because we're using those antibodies to diagnose the patient and trying to put them into a category of what's the best way to treat them. We're going to show some of those categories a little bit later. But the other key to remember is that the patient can still come to us with symptoms of weakness and double vision and drooping eyelids and have normal blood tests. And that's kind of the nemesis for us now because those are so-called seronegative myasthenia. And we've got some new things in the pipeline that's coming. So this is the picture that you don't want to forget or may have never seen before, but the way nerves and muscles talk to each other is a nerve comes up to a muscle and stops short. When an impulse comes down the nerve, chemicals are released that attach to the muscle and cause it to contract or to move or to whatever you want it to do. In the disease myasthenia, you've developed antibodies to those receptors. So here's a picture. I don't have a pointer. That's okay. Here's a picture. At the top is the bottom of the nerve. At the bottom is the muscle. And in between are all these things called the synaptic cleft. And in the synaptic cleft, there's a whole variety of proteins and things at the other end that have to be stimulated for the muscle to work. So the acetylcholine receptor antibody, the modulating antibody, the binding antibody, now the MuSK antibody, and the new ones that just came up are the Titin antibodies, which are directly on the muscle fibers themselves. And what we're beginning to do is to develop a sensitivity for trying to understand what these mean in terms of degree of illness and a prediction for what's going to happen to the patient. But this is kind of what's happening at the microscopic level everywhere in your body. The new muscle-specific kinase antibodies can be detected in a subgroup. So now we're looking at the so-called acetylcholine receptor negative patients and trying to subdivide those patients. And there are patients that have these other antibodies that we have not been classically looking for, which we can now find, which mimic the same symptoms as myasthenia, putting that list a little bit longer. Again, the acetylcholine receptor, binding, blocking, modulating, MuSK, Titin. The list is getting bigger as we're getting better at understanding this. And there are some patients that are so-called double seronegative. We're doing as many tests as we can. Looks like a duck, walks like a duck, quacks like a duck. It's got to be myasthenia. Why are all the tests normal? Because there are a few patients in which they are. And the other thing, it also depends how you're testing. So there are some standard laboratory tests, and then there are so-called cell culture-based testing, which may be far more sensitive, which we're beginning to utilize more and more. 90% of patients have autoantibodies against the muscle nicotinic receptor, the so-called acetylcholine receptor antibodies. The other patients can have these MuSK antibodies. They've been detected in half of that remaining 10%. But there's a new one, a low-density lipoprotein receptor-related protein antibody. So that the alphabet soup is getting bigger. And the alphabet soup is getting bigger as we're beginning to understand more and more of the way nerves and muscles talk to each other. And again, these so-called double seronegatives may have the LRP4 or L whatever, antibodies, and they also may have antibodies that cause myasthenia. So the anti-LRP4 may cause myasthenia, but you'll be otherwise receptor negative. So in my world, we're starting to look at all of these different subtypes so that we can understand what to tell patients. In review, it's an autoimmune disease. The antibodies induce weakness of the muscle. The weakness can be generalized or localized, more proximal than distal. Nearly always includes the eye muscle. Nearly always means about 80%. Over the course of a life of a patient with myasthenia, 80% will have some vision symptom. The pattern is usually symmetric except for the eye. It's one of the few things that drives the ophthalmologist a little crazy, and we'll talk about how we do that eye exam a little bit shortly later. The weakness increases with exercise and fatigue and improves with rest, varies from day to day. The hallmark of this disease is variability. And unfortunately, most of what we do in ophthalmology also is a static solution to a static problem. If somebody comes in and says, I always have double vision side to side, except when I look to the left, it's like this. When I look to the right, it's like this. I don't have a prism that goes like this when you look to the right and like this when you look to the left. So I can fix it straight ahead. And that's one of the problems, and we'll talk a little bit later about how it's difficult sometimes to find a prism solution, but still we've tried. It's an annual incidence of 8 to 10 cases per 1 million. So this room should be bigger next year. 150 to 250 cases per 1 million over myasthenia and its various subgroups are the major diseases that affect the neuromuscular junction. The Eaton-Lambert syndrome is a myasthenic type syndrome that usually occurs with cancers. We usually see this in patients with cancers elsewhere who are now developing symptoms that look like myasthenia, and it's the Eaton-Lambert syndrome. It's confirmed by a combination of relevant symptoms and signs and positive tests for specific antibodies. And if you don't have them, then we can go ahead and start doing neurophysiologic tests. So neurophysiologic tests involve the electromyogram, the EMG, and variations on the theme called the single fiber EMG. And what we're trying to do is we're trying to develop an armamentarium of data that supports that the patient has myasthenia. In antibody-negative cases, tests, like I said, the EMG, and a characteristic response to therapy secure the diagnosis. On Friday morning, I was given a call by one of my colleagues at Rush on a gentleman that I saw last November. His only symptom was variable double vision part of the day, but then he would concentrate or shake his head, it would go away. I saw him the third week of November. He said, come back in a few months, let's see what happens. He said, okay. I got the call last Friday from his doctor. Oh, he's here now and he can barely open his eye up. Oh, so now he's got double vision and a drooping eyelid. That makes my job a little easier. That doctor was smart enough to do the ice pack test. And that's what his next sentence was. Oh, by the way, I ran and grabbed an ice pack, put it on his eyelid, and it came right up. I said, well, we know who to call. So we're calling the myasthenic neurologist. I'm going to see him this coming Wednesday or Thursday to start talking about what I'm going to do, which is going to come a little bit later after they start treating him. But now he flowered into myasthenia over 4 months when his first symptom was a little bit of double vision. He never had that before. Comes and goes, doesn't stop him from doing what he wants to do, and the exam looks stable except for a little bit of double vision. Nothing that would make me want to do a brain scan for a tumor or an aneurysm, but come back in 4 months was the answer. If he had come to me first, I would have made the diagnosis. But his doctor did. It's very good. So what do? What we try to do is we try to have therapy which has an effect, prognosis regarding muscle strength, functional abilities, quality of life, and survival is generally good. Therapy should be aimed at full or nearly full pharmacologic remission. And that's a big word, remission. We treat a lot of things. We don't cure a lot of things. But remission is a good word for myasthenia because it helps people live a better life. But then we get to this issue, which is what I spend my time doing in my clinic. About 15% of all patients, their signs and symptoms are confirmed just to their eyes. Half the patients with ocular myasthenia have detectable antibodies. Only half do. The other half don't. This is the acetylcholine receptor modulating and blocking antibodies. When I teach residents at Rush, as I have since 1985, I would tell them when you get the antibody test for these patients, if it's positive, it's great. If it's negative, we have no idea. The patient may still have the disease because 50% will show antibodies and 50% won't. Those are the classic antibodies, not the special antibodies. The special antibodies haven't been defined yet, and we might be getting better at making this diagnosis as we get better with these special antibodies. Ptosis, drooping of the eyelid, and double vision are common symptoms. Here's my patient that I'm going to see this Thursday. He had them develop over 4 months. But it can remain restricted to the ocular muscles in only a minority of patients, between 15 and 20%. If you look at all patients with myasthenia over the course of their lifetime, about 80 to 85% will have a visual symptom. If you look at a patient who presents just with visual symptoms, if they make it out about 2 to 2.5 years without generalizing, it's probably just going to stay in the eyes. And staying in the eyes is okay, but it's a nemesis because the hallmark of their visual symptoms is variability. It never stays the same. It changes. And one of the problems is that my solutions to the eye symptoms are static solutions to static problems. Patients don't have static problems. Myasthenia gravis with MuSK antibodies is not manifested as ocular, again, helping us to know that if the patient has these antibodies, we might be looking elsewhere for neuromuscular disease. Again, we don't know enough about the LR4P antibodies. So what do? We have a group of patients. Everybody thought myasthenia was one umbrella. Well, it's a big umbrella. It's a big umbrella that has to have all these people underneath it. The ocular, the early onset, the late onset, those with and without thymoma, those with and without the LRP4 antibodies, those with just MuSK antibodies, and then they coincide and they overlap, as you see on the right-hand side, with these other coexisting conditions. And what we try to do is to define the patient based upon what we see on the left and what we see on the right to try to determine what's the best therapy to pursue. So here's how you define it. The early onset group is usually less than 50. A late onset group usually greater than 50. Patients with thymoma can be any age. Muscle-specific kinase, any age. As for the LRP4, seronegative and ocular. So there are some things that we can define by how they start, when they start, and what they do that will help us decide what to do. And then we'll talk about the thymus gland because that's going to be important. But this is how we kind of define the disease clinically with ages of 50, under 50 and over 50. So how does the eye work? First of all, the eye is a camera, sends an image to the brain. It's important to remember the eye does not see. The eye doesn't do any integration at all, just a camera. All the integration comes up in the brain. The movement of the eye is controlled by 6 muscles. 1 out, 1 in, 2 up, 2 down. 6 muscles controlled by 3 nerves. 1 nerve goes to the muscle that pulls the eye out. 1 nerve goes to the muscle that pulls the eye down and in. 1 nerve goes to the other 4 muscles plus the eyelid. What you have to do then is you have to coordinate that movement. So that's a lot of muscle. That's a lot of movement. It has to be extremely precise. We then have this in each eye. So now you need to remember that in the brain, there has to be a computer controlling 6 nerves to 12 muscles to keep things straight all the time. And that's the trick of vision here. So at night when we sleep, our eyes roll up and out. When we wake up in the morning through a process called fusion, you develop single binocular vision. The job of the computer, keep your eyes straight all day long no matter where you're looking. Move 6 nerves to 12 muscles precisely within a millimeter of each other at an instant. And the computer knows what it's doing because the computer is working. What we're seeing in myasthenia is end muscle disease. This is where the muscle and the nerve are interacting in the orbit, out of the brainstem, producing the double vision. So throughout the day, eye movement control maintains fusion to see one object, and double vision or diplopia results when the 2 eyes aren't lined up. It can occur as a result of underaction of any of the muscles, and that's one of the problems with myasthenia. It produces this, I've had patients with horizontal, vertical, oblique, and torsional diplopia, and variable. Well, it's only bad when I blank. You know, doctor, it hurts when I do this. What should I do? The answer is don't do this. So it's one solution. Anyway, double vision also varies in positions of gaze. Double vision can also vary throughout the day because of fatigue, and the variability is characteristic of myasthenia, which makes this extremely difficult to treat with constant treatment. I mean, I can, you know, when I do measurements in the office, I have the patients looking at a target, and I'm lining up prisms. And too frequent, more than not, patients will say, well, this is good if all I did all day long was sit still and not move my head. I know, but I don't have a machine that measures that. And you don't sit all day long with your head not moving. Your head's moving, your eye's moving, and here goes your eyes wherever you want. Very difficult to fix. So first we want to determine the nature of the double vision, attempt to neutralize the double vision with prism in the glasses, attempt to determine a solution which works for the majority of the time. I tell patients that when we use prisms and glasses to try to adjust double vision or neutralize it, we apply the Abraham-Lincoln rule. The Abraham-Lincoln rule is you'll never make all the people happy all the time. So you know you're never going to have a solution that works all the time. I actually have patients with myasthenia that also have several pair of glasses. One for distance, one for reading. I have one patient who has glasses for morning, glasses for evening. Why? Because the evening glasses have more prism in it. And the variable nature makes it very difficult to treat. So, separate pair of glasses, more prism as we need to. Now, what can we do about it medically? The ocular symptoms tend to respond better to prednisone than Mestinon, even though Mestinon is your first-line drug, because 80% of patients are still going to have systemic myasthenia and need Mestinon. The ocular symptoms may improve following removal of the thymus gland if it's present, which is why we're now scanning everybody's chest and trying to get the thymus removed. We're going to talk about that in a little bit. The eye movements also with myasthenia can affect the eyelid. Now, the drooping eyelid is very difficult to fix. It's called ptosis. And ptosis, we can sometimes use medications, but sometimes we have to use mechanical devices like a ptosis crutch or even surgery to lift up the lid. All right. So what are the drugs most commonly used? Well, there's a whole army of them. So first it's pyridostigmine, followed by prednisone, followed by azathioprine, followed by Cellstep, and then we're getting into the other stranger drugs, the Rituximab, the Methotrexate, cyclosporine, tacrolimus, cyclophosphamide, and IVIG. This is in the armamentarium of the neurologist to decide what are we going to do in order to make this patient's life better. First, starting with Mestinon is easy because the side effects are usually tolerable. The other problems with prednisone are diabetes, high blood pressure, ulcers of the stomach, and osteoporosis. So I have a young gentleman that I've treated for 3 years with ocular myasthenia, 10 milligrams of prednisone a day, no double vision whatsoever. At 3 years and 1 day, he woke up, stood up, fell down, dissolved his right hip. Why? Because that's what prednisone does. But he had no double vision. So we asked, do you want to stop the prednisone? He said no. So he went and had his hip replaced. As he had his hip replaced, the doctor said, you know, the other one's going. He said, I'll call you when it goes. So we're now into 3 years into that. But it's not uncommon to get side effects from prednisone that you have to live with. And if you can live with it, then you're doing good. And what do we do? What's the diagnostic diagram? So the diagnosis is confirmed. Then we try something simple like Mestinon. If that doesn't work, then we add prednisone. If that doesn't work, then we start adding other medications or switching. And some of the switching stuff that we're doing is either adding Cellstep for mild disease or even doing stuff like plasma exchange and ocular immunotherapy with IVIG, which works very well. Coexisting conditions. Most patients have myasthenia not in isolation, but they have something else, and the something else is usually lupus or rheumatoid arthritis, again, an autoimmune disease, just telling us that the patient has this tendency for autoimmunity. In patients with ocular myasthenia, thyroid disease is especially common. So myasthenia occurs in 1/3 of all patients with a thymoma. We're going to talk about that next. Treatment can increase the risk of coexisting disorders, and prednisone with osteoporosis, weight gain, diabetes, and hypertension are real. So all subgroups can respond to pyridostigmine in different doses, but side effects are real, so you have to monitor, especially abdominal and gastrointestinal. But most patients are capable of adjusting their own dose throughout the day to minimize these side effects or to monitor them and see what we can do about them. Most need immunosuppressive medication to meet treatment goals. Prednisone or prednisolone in combination with azathioprine is usually our first line of therapy. It's added because the combination provides better functional results with fewer side effects. The effect of myasthenic weakness often takes months, though, so you have to use azathioprine with prednisone for a long time. What do we do for the eyes? Ocular myasthenia to prevent generalization. We're not quite sure how to do that yet. We know that there's studies that indicate that if we give patients with ocular myasthenia prednisone, we might be able to prevent it from spreading, but this is not yet uniform. There is no consensus that that is the best or only treatment. Low doses of glucocorticoids is therefore recommended by many experts, and you have to look to see what else could we add. So detectable acetylcholine receptor antibodies and enlarged thymus or other neurophysiologic tests tell us that there may be involvement of other muscles that haven't become symptomatic yet. So this may not be pure ocular myasthenia, but prednisone helps those patients enormously. Cellstep is recommended for mild or moderate. Other drugs are added if these drugs don't work. What has evolved in the last several years, and you may have heard about it in the news, is this set of intravenous injections which represent potent inhibitors for inflammation. Rituximab is one of them. It's a very specific monoclonal antibody for CD20 that stops inflammation in many, many places. We've looked at it in thyroid eye disease. We've looked at it in orbital inflammatory disease. We've looked at it in other patients with inflammations elsewhere. It's very successful, but very potent. These drugs all have side effects. You know, the newer drugs that have just come out, which haven't been tested yet in myasthenia, are called checkpoint inhibitors. The checkpoint inhibitors release the T cells, and let them go and do very good things in your body by eating up cancers. Jimmy Carter is alive today because of checkpoint inhibitors. And just to go back a little bit, when you take somebody who's 91 years old and has metastatic melanoma to the brain, that was an incurable disease 10 years ago. There was no treatment. There was no treatment. Now we give checkpoint inhibitors. The body's own immune system ate up his cancers. He's currently cancer-free. But there's an equal number of patients that when you release the dogs, suddenly the immune system eats up your liver and your spleen and your kidney and your heart and your brain. So you got side effects from these dogs, and we have to be careful how we use them. But it's coming. I think as we get better at trying to decide who's who and what's what, we're going to do better. I think one of the exciting things that's happened in the last few years is what we've done with thymomas. So if a patient has a thymoma, taking it out is probably beneficial. But it has kind of been the rule for the last 5 to 7 years. The problem is the thymus gland is right underneath the chest bone next to the heart. So it wasn't an easy thing to do. I mean, it was an open chest procedure until a few years ago. I know I think his name is Gianelli at the University of Illinois, one of the best robotic surgeons in the Midwest. He has done several of these where they do it purely robotically with 3 or 6 1-inch incisions. The robots go in and he controls it, takes out the thymus gland, patients go home in 48 hours. This robotically assisted surgery has been remarkable because now patients can have thymectomies done. We don't have to worry about it, and they actually do better. So you have to look at the status of your thymus gland when we're talking about myasthenia and how to treat it. So, confirmed a distinct benefit from early thymectomy in patients with generalized disease, duration of less than 3 to 5 years, age less than 60 to 65, symptoms not fully relieved by medications, and then all thymic tissue needs to be removed, which is what the video and robotic-assisted methods can do to minimize surgical procedures and complications. So it also should be considered in patients with generalized myasthenia who have antibodies whose symptoms develop at the age of 50 to 65 years. And so you can see that as we're getting better at doing thymectomy, that the indications for doing it are becoming more and more. Certainly in children, we take them out. In young people, it comes out. And, consider for the treatment of ocular myasthenia only when drug treatment has failed, the patient has receptor antibodies, or tests indicate the risk of generalized disease. For pure ocular myasthenia, thymectomy has not been shown to be valuable. So what do we do for the patients? You try to do physical activity and systemic training programs, try to avoid muscle relaxants, certain antibiotics, oral administration of methadone and prednisone, certainly safe during pregnancy. Monoclonal antibodies have selective binding and high specificity regarding immunologic actions, so we're trying to find the right receptor for the right muscle to try to fix this. And they're being developed. They're being developed for other autoimmune diseases, and eventually myasthenia will come into play. So in summary, we establish the diagnosis with appropriate clinical symptoms and testing, consult the neurologist for treatment. I don't treat myasthenia, I just treat the ocular symptoms, and then consult the ophthalmologist for ocular symptoms of ptosis, double vision, and then eyelid disorders with either prednisone or ptosis crutches, and possibly even Are there any eye exercises that can slow down the bubble head or double vision? The bubble head sensation is when you look from one spot to another, one eye gets there a half a second before the other. So it gets here, and then this eye catches up, and your image just goes like this. Keep shaking. Unfortunately, no. There is no exercise that can help that. Prism might help that. The question that was asked is, why one eye only? Why, if myasthenia is this generalized disease throughout the body, why isn't it affecting both eyes at the same time to the same degree? Great question. That's the trip to Norway to win the Nobel Prize. We don't know. We know that the antibodies throughout the body are expressed everywhere and anywhere. Why they hit one eye more than the other or one muscle more than the other is yet to be defined. We don't know. It would be interesting if we can start developing some of these assays to look at these very specific receptors on muscles to see maybe there's more in one muscle than the other. Maybe we'll have an assay in the future that will tell us why one thing is happening more than the other. Unfortunately, again, when I see a patient with double vision, my first goal is to make sure it's not a tumor or an aneurysm. That's life-threatening. So the next thing I have to do is it due to eye muscle disease. Thyroid eye disease can mimic myasthenia easily. And the next thing I have to decide is it a result of a cancer elsewhere? So when I'm looking at a patient, I'm looking at the pattern of the deviation. Does this fit any rule? Because classically, myasthenia doesn't. And in fact, when nothing fits the rule, think myasthenia. And when I teach residents, when you're trying to develop a system of trying to decide what to do with patients with double vision, number 9 on the list of 10 is always myasthenia. It's never off the list. It can occur in any fashion, in any way, in any shape. So why? So what's happening is, again, when I do my measurements in the office, I'm looking at static measurements. Look at the chart, I put a prism up one way or the other, and suddenly I see one. But when you realize when you're trying to move your eyes side to side in each corner, number one, they might be moving with a different velocity. That's what the so-called bubblehead thing happened before. So I look to the left, and this eye gets there quickly, and this eye takes a half a second to get there. So right before these two images fuse, it's blurry. And that's what's happening to you with things that are moving around, because you're trying to find out where in space these things are, and your eyes aren't tracking together. Unfortunately, if it becomes a big problem, if you're not on medications already, medications may help. But the next thing that may help is simply trying to experiment closing one eye. See if that makes it better. My strong suspicion is that it's going to make it much better. And the problem, again, is depth perception. I've had myasthenics that I've seen early on, and we've talked about this, and monocular occlusion, and come back to see me in a couple months, and they come back and they got a cast on their right arm. That doesn't look good. What happened? I closed the eye, I went up the stairs. No, you're supposed to hold to the rail and go up the stairs, and you close one eye. I didn't do it, and went down and put her wrist down and broke her arm. Bad lesson to learn, but it happens. And so you do want to be careful. And certainly when you're driving, closing one eye is, if you're going to drive and close one eye, I just need to know what you're driving. So if I see you coming down the street, I'll pull over. Get out of your way. So you need to be careful. It's not impossible. The state of Illinois doesn't require you to have two eyes to drive. It just requires one eye that's working to drive. Are there one-eye drivers? There are one-eye drivers all over the place. There are one-eye pilots that fly their own plane. They just don't do it in the first 3 months, because it takes around that long for your brain to figure this out. So is it possible that you could wear a patch and do this? The answer is yes. Now, the advantage to wearing a patch is that it makes the double vision go away. The disadvantage to wearing a patch is it makes your brain lazy. Your brain has no interest in putting both eyes together if it doesn't see double. So then you got to sit down and try to decide, well, when do I want to see double and not? Well, sitting at home and watching television, moving your head, well, I can see perfect right here. I watch television like this. Well, you get a pain in your neck eventually, but you can do that. But driving, you don't have that option. And if you have to drive and you have to wear a patch, it is life and you have to do it. But then you have to sit there on the weekends with people next to you and drive with that patch on until you learn monocular depth perception. And once you learn one-eye depth perception, fine. Then you're ahead of the curve. That's okay. No problem with that. All right.